Imagine you're standing on the deck of a ship, right? You're in the freezing ocean, and you spot an iceberg. You see this brilliant, jagged peak of ice rising out of the water. And, for centuries, if you were a sailor or an explorer, that peak was the only thing you cared about. You mapped it, you navigated by it, and you confidently thought, well, I understand exactly what this is.
Right, because, I mean, the surface peak was the absolute limit of your interaction with it. If it wasn't visible above the water, it essentially didn't exist in your reality.
Exactly, it wasn't there. But we all know the terrifying truth about icebergs today, right?
Mhm.
That visible peak is, it's nothing. It's a tiny, almost insignificant fraction of the actual reality. Because beneath that dark surface of the water, there's a massive, complex, hidden mountain of ice. And if you ignore what's beneath the surface, you are completely missing the actual picture.
Missing the whole thing, yeah.
Which is exactly why we're taking this deep dive today. We are plunging beneath the surface for you to explore the fascinating, highly complex, and honestly deeply misunderstood anatomy of the female reproductive system.
And, this isn't just an anatomy lesson for the sake of having an anatomy lesson. Understanding this hidden structure it's the key to a massive shift in medicine right now. We're going to examine how a non-surgical regenerative treatment called the O-shot is actually using the body's own biology to restore function, alleviate pain, and enhance pleasure.
In ways that, honestly, the medical community previously thought were just impossible.
Completely impossible, yeah. They had no idea.
Because for years, if a patient came in complaining of painful intimacy or incontinence, the standard treatments were either highly invasive surgeries or artificial fillers.
Right. It was like we were trying to fix a complex machine without even having an accurate blueprint of how it was built in the first place.
Yeah, exactly. So let's map the terrain. Let's take that iceberg analogy literally for a second. When we talk about the clitoris, which is drastically different from what almost everyone assumes, what exactly is the tip of the iceberg?
Well, the tip of the iceberg is the glands of the clitoris. This is the external portion, that small nub of flesh that's located at the top of the vulva just under the clitoral hood. And for generations, in medical textbooks and definitely in popular culture, this tiny external point was what everyone referred to when they said the clitoris.
Right. That was the whole thing as far as anyone was concerned.
Exactly. But structurally speaking, the glans only measures about 5 to 8 millimeters in length.
Wow.
Yeah, that represents less than 1/4 of the entire organ.
5 to 8 millimeters. That is incredibly small. It's essentially the size of a pencil eraser.
Right.
But beneath the surface,
it is a massive, highly intricate structure. Inside the body, the clitoris is shaped, sort of like an upside-down wishbone or a large V shape. So right behind that visible glans is the body of a clitoris, which then splits into two distinct legs, which we call the crura.
and these legs, these crura, they're not just small structures floating around in there, right? Like they are anchored deeply into the body.
Oh, they are deeply integrated. The crura are about 50 millimeters long.
Wait, 50 millimeters. So the tip is 5, but the legs are 50.
Exactly. It's a huge difference. To visualize that, they extend deep into the tissue of the vulva, and they physically attach to the ischiopubicral rami.
Okay, just to give a visual for that, for you listening, ischiopubicral rami, those are essentially the bony arches of the pelvis, right? Like the bones you might feel if you were sitting on a really hard bicycle seat.
That's exactly right. They anchor to that bone, and they run right alongside the vaginal walls, wrapping around the structures there. And the internal anatomy doesn't even stop with the crura. It also includes the vestibular bulbs.
The vestibular bulbs, which those sit on either side of the vaginal opening, I imagine these functioning almost like a biological cushion or a sleeve.
Very active sleeves, yeah. Because these bulbs, just like the clitoral body and the crura, they're composed entirely of erectile tissue. The clinical term for that is the corpus cavernosum, which translates literally to cave-like body.
Cave-like body, okay.
Yeah, it's essentially this dense network of spongy tissue. So during sexual arousal, this entire internal network fills with blood. These structures can actually double in size.
They double in size.
Yeah. And when you realize that this massive, blood-engorged wishbone structure wraps right around the vaginal canal, you start to understand how its physical expansion creates internal pressure on the vaginal walls.
Right.
And that expansion contributes heavily to physical sensation.
I think this is where the historical blind spot becomes so glaring, right? We treated the female anatomy like it was just this tiny surface structure, completely ignoring this massive dynamic engine sitting right behind it.
Exactly.
Okay.
We ignored the engine.
But it's not just about the erectile tissue and physical size, is it? It's about the wiring. Because the nerve density here is staggering. When clinical researchers finally started mapping the nerves on a microscopic level, they found something incredibly specific about the dorsal nerve.
They did. So the branches of the pudendal nerve, which is the main nerve of the perineum, they come together to form the dorsal nerve of the clitoris. And anatomical studies show this highly concentrated, almost overwhelming nerve density, specifically on the dorsal half of the clitoral body.
Okay, so if we imagine looking down at the cross-section of this clitoral body, like, say, like a clock face, where are these nerves located?
They spread out specifically between the 11 o'clock and 1 o'clock positions. That is where all those dense bundles of electrical wiring are concentrated.
So we have this hidden upside-down wishbone spanning roughly 50 millimeters in length, packed with an intense concentration of nerves right at the top between 11 and 1 o'clock, with massive bulbs that engorge with blood. It's a brilliantly complex biological machine.
It really is.
But machines break down.
And that is the crucial context here. Knowing that this delicate, intricate network exists beneath the surface, it perfectly explains why natural life events cause such profound disruption. I mean, think about the drop in estrogen during menopause, the natural aging process, or the intense physical trauma of childbirth.
Right.
All of these things impact this hidden iceberg. The tissue loses its robust blood supply, the structural collagen breaks down, and those dense nerve bundles can become physically damaged or desensitized.
Which naturally leads to a whole cascade of real-world quality of life issues. We're talking about vulvovaginal laxity, severe vaginal dryness, painful intercourse, which I think is clinically known as dyspareunia.
Dyspareunia answer.
Right, and urinary incontinence. And historically, the medical answers for this have been pretty bleak, haven't they?
Very bleak. I mean, a patient might be offered topical hormone creams, which really only address the surface level temporarily. Or in extreme cases, they were offered invasive surgeries that actually cut into the pelvic floor tissue.
Which sounds incredibly risky.
The cruel irony there is that surgical cutting risks severing the very nerves we just mapped out. Or practitioners would inject artificial cosmetic fillers, like hyaluronic acid, to plump up the lax tissue. But fillers just take up space.
Right, they don't fix the machine.
Exactly. They don't heal anything, and they actually carry a real risk of blocking blood vessels.
Which perfectly sets the stage for this targeted regenerative approach called the O shot, or the orgasm shot. This is a non-surgical, minimally invasive procedure that happens in a doctor's office in, about 30 to 45 minutes?
Just read about that, yes.
And the major distinction here is that it doesn't use synthetic chemicals or artificial gels at all. It uses PRP.
Platelet-rich plasma, yes.
Yeah.
This is a foundational pillar of modern regenerative medicine. I mean, we see it used in orthopedics to heal torn tendons, we see it in dentistry to heal gums, and now finally in regenerative gynecology.
I want to walk through exactly what this looks like for the patient, because the process starts with a simple blood draw from the arm, just like a standard physical right. But instead of sending it to a lab for testing, that small sample of the patient's own blood goes into a centrifuge.
Right. The centrifuge spins the blood at very high speeds, and what this does is it separates the red and white blood cells from the platelets and the plasma.
Okay.
So it isolates and concentrates the platelets, leaving you with this clear kind of golden serum. And that serum is packed with your body's own natural healing properties.
And then this concentrated golden serum is injected back into the body, specifically into the O spot, which is the anterior vaginal wall near the urethra and periurethral glands, and directly into the clitoral corpus cavernosum, that spongy wishbone body we talked about earlier.
Correct. That is the core injection protocol.
Okay, I have to stop right here, because we really need to view this from the patient's perspective for a second. You just spent 10 minutes explaining that the clitoris has an overwhelming, highly concentrated density of nerves right on its surface. It's literally one of the most sensitive areas on the human body.
It is.
And now you are telling me a doctor is going to take a needle and inject fluid directly into it. I mean, that sounds like absolute agony. How is this not a terrifying, painful experience?
Look, it's the most common and honestly the most valid fear patients have. But the clinical protocols are built entirely around mitigating that sensation. First, a highly potent medical-grade topical numbing cream is applied to the entire area and left to sit for about 15 to 20 minutes.
But wait, numbing cream on my arm wouldn't stop me from feeling a needle puncture deep into the tissue. Why does it work so well down there?
Because of the type of tissue. The vulvovaginal area is mucosal tissue. Unlike the skin on your arm, which has a tough, thick, keratinized outer layer designed specifically to keep things out.
Oh, right, it's permeable.
Very permeable. Mucosal tissue is incredibly porous. It absorbs the anesthetic rapidly and deeply, right down to those nerve endings.
So the tissue acts like a sponge for the numbing cream.
Exactly. It gets thoroughly numb.
Mm.
And secondly, the needles used for the PRP injection are incredibly fine. We're talking about the microscopic gauge needles used for delicate facial Botox.
Oh, wow. Tiny.
Very tiny. And finally, because the doctor is using an FDA-approved kit specifically designed for PRP preparation, the serum is pure. There are no inflammatory chemical additives. Most patients report feeling, a slight pressure, maybe a strange fullness as the fluid enters, but little to absolutely no sharp pain.
Okay. The mucosal absorption of the lidocaine is doing the heavy lifting, and the needle is microscopic. So let's dive into the actual biology of the repair. The PRP has been spun down, the golden serum is drawn up, and it's been injected into the O-spot and the clitoris. What is actually happening at a microscopic cellular level? Because earlier we noted that artificial fillers just sit there like a silicone implant. This is different.
Oh, it's completely different. PRP is biologically active. So the standard protocol calls for injecting 4 milliliters of PRP into the O-spot and 1 milliliter directly into the clitoris. But right before injection, that PRP is activated with a tiny amount of calcium chloride.
What does that do?
Well, when those activated concentrated platelets hit the tissue, they essentially degranulate. They burst open, releasing a massive payload of growth factors into the surrounding area.
Right. Clinical studies list a whole alphabet soup of growth factors here.
Right.
PDGF, TGFB, VEGF, and EGF. What are these actually doing?
Yeah, the alphabet soup. They stand for platelet-derived growth factor, transforming growth factor beta, vascular endothelial growth factor, and epidermal growth factor. But really think of these proteins as your body's emergency signaling molecules. They act as messengers commanding the local cells to regenerate.
Okay, so give me an example.
For instance, VEGF specifically triggers angiogenesis.
Angiogenesis being the creation of brand new blood vessels, right?
Right. It forces the tissue to build new vascular highways, which brings oxygen and vital nutrients back to tissue that has literally been starving for it. Other factors trigger collagen synthesis, creating new elastic structural support. And crucially, they promote nerve regeneration.
I love visualizing this. It's essentially like sending a localized distress beacon to a cellular construction crew. You're commanding them to rush to a deteriorating highway, rip up the old road, lay down fresh, bouncy pavement, which is the collagen, and then meticulously repair the frayed insulation on the electrical power lines, meaning the nerves.
That is the perfect analogy, yes. You're literally commanding the body's construction crew to rebuild the infrastructure from the inside out. And we know this fluid reaches the entire site because clinical ultrasound imaging actually captures it happening in real time.
Wait, I would assume an ultrasound just shows like a dark pool of liquid sitting exactly where the needle went in?
Not at all. The ultrasound shows the liquid actively hydrodissecting the area. Because the corpus cavernosum is spongy, right? The fluid actually parts the tissue layers and passes deep into all parts of the clitoral wishbone.
Oh, it travels.
It travels. It completely bathes the Skene glands, which are the periurethral glands responsible for natural lubrication, essentially the female equivalent of the prostate. The tissue sucks up the PRP serum like a dry sponge being dropped into water, drawing those growth factors far beyond the initial injection site.
Which brings up a fascinating and, frankly, a critical mechanical question. If this internal wishbone is completely hidden beneath the surface and a doctor is holding a needle, how do they know exactly where to inject to hit the sponge without hitting those dense nerve bundles? Because you mentioned earlier that the nerves sit at the 11 and 1 o'clock positions.
This is where specialized clinical training becomes completely non-negotiable. And it brings us to one of the most vital insights from recent anatomical research. It's about anatomical variation. The variation in the location of the clitoral crura drastically influences how a doctor has to angle their needle. This is known as the lateral injection vector.
Let's break that down. Anatomical variation. Meaning my hidden iceberg might look completely different than your hidden iceberg.
Wildly different. Yeah, researchers actually conducted studies on unembalmed cadavers to map these internal structures precisely.
And what did they find?
What they found was that there is absolutely no standard uniform measurement. For example, the distance from the dorsal nerve, right where it emerges from the perineal membrane, the hammock of muscle supporting the pelvic floor, to the mid-pubic arch, ranged anywhere from 20 millimeters to 48 millimeters, depending on the person.
Wow.
And the distance from the external glands to the urethra ranged from 14 to 37 millimeters.
Wait, 20 to 48 millimeters? I mean, that isn't just a slight variation. If you're a doctor holding a microscopic needle, a difference of nearly 3 centimeters is the difference between hitting your target perfectly or missing it entirely.
Exactly. There is no standard X marks the spot on the human body. Because the crura, those 50-millimeter long legs of erectile tissue, wrap around the vagina and attach to the pubic bone at slightly different angles and lengths for every single woman, the practitioner cannot use a one-size-fits-all approach. They have to dynamically adjust their lateral injection vectors.
Lateral, meaning they're coming in from the side.
Yes. Remember that clock face?
Right, 11 and 1.
The dense, vulnerable nerve bundles are sitting right on top at 11 o'clock and 1 o'clock. You never want to inject straight down into those nerves, so the doctor has to insert the needle laterally from the side to safely bypass those surface nerves and deliver the PRP underneath them directly into the spongy corpus cavernosum.
Okay, that makes sense.
But because of that anatomical variation we just talked about, the exact angle and direction of that side approach, it must be customized to where that specific patient's crura actually are.
That makes total sense. If their vector is off because they assumed everyone's anatomy is identical, they might miss the spongy tissue entirely and the PRP just pools in the wrong place. Or worse, I guess they accidentally clip that dense bundle of dorsal nerves.
Precisely. And the success of the entire cellular construction project depends on hitting the spongy tissue so it can soak up the fluid. When the lateral injection vector is calculated correctly based on the patient's unique anatomy, the golden serum safely bathes the entire internal network. It really underscores that your anatomy is uniquely yours.
It's a powerful reminder that you can't just walk into, any random med spa for this. It requires a practitioner with a deep 3D spatial understanding of this hidden anatomy. So we have the biology, we have the precise injection vectors. How does this microscopic repair job actually translate into a patient's daily life? Because they don't feel angiogenesis happening, they just know their body feels different.
Right. Well, the real-world functional improvements are dramatic, and they develop gradually over several weeks as the tissue physically remodels itself. Let's start with a massive functional hurdle: urinary stress incontinence.
Okay.
This is when normal physical activity like coughing, laughing, or going for a run puts sudden pressure on a weakened bladder and urethral sphincter, causing urine leakage. The O-shot has an estimated 90% success rate in addressing this.
90%. That is life-altering for someone who has been living with the daily anxiety of leaking every time they sneeze. But wait, I want to connect the dots here. We've been talking about injecting the clitoris and the tissue near the vaginal wall. How does treating sexual anatomy cure a urinary bladder problem? Is it because those 50-millimeter crura and the vestibular bulbs physically wrap right around the urethra?
You nailed it. The anatomical proximity is everything here. When you use PRP to rebuild the collagen and rejuvenate the erectile tissue of the clitoris and those vestibular bulbs, you are simultaneously plumping up and strengthening the structural tissue directly surrounding the urethra.
Oh, wow.
Yeah, you are essentially building a biological buttress that supports the urinary tract.
That is incredible.
Furthermore, the nervous system is highly interconnected here. The pudendal nerve branches control both the pelvic floor muscles used in urination and the sensory input for orgasm. So by bathing this entire overlapping hub with growth factors, you tighten the urethral support system while simultaneously waking up the sexual response system.
It's an incredible 2-for-1 benefit born purely out of understanding how the body's architecture overlaps. And on the sexual response side, the benefits seem just as profound, because by repairing the skin glands and building new blood vessels, you are naturally alleviating dyspareunia, that painful intercourse and severe vaginal dryness.
Right, because instead of relying on a temporary, messy external lubricant, you have repaired the patient's own glands so they function naturally again. The tissue becomes healthier, it's more supple, and it's properly hydrated from the inside out.
And it goes beyond just getting back to baseline or stopping pain. It actively enhances pleasure. I mean, clinical data points to improvements in vulvar skin texture, increased physical responsiveness of the clitoris, and a real heightening of arousal and orgasm intensity.
Yes.
Some patients even report an increased frequency of peak experiences simply because those frayed electrical wires and nerve pathways have been repaired and resensitized by the growth factors.
And if we look at the safety profile, it's remarkably clean because the O-shot relies entirely on autologous blood, meaning it's the patient's own blood. The risk of allergic reaction or tissue rejection is practically zero.
Because you can't be allergic to yourself.
You simply cannot be allergic to your own plasma.
Exactly. The side effects are typically minor and temporary, usually just mild spotting or localized sensitivity for a day or two. And the positive results from that single 30-minute biological upgrade can last anywhere from 6 to 18 months, and in some cases, even longer, as the tissue maintains its new infrastructure.
It really is a paradigm shift in how we approach healthcare. We are moving away from masking symptoms with synthetic treatments or cutting into tissues we just don't fully understand. We are moving toward utilizing the body's innate intelligence to heal itself, provided we finally respect the anatomy enough to know exactly where to deliver the instructions.
That's the key. The healing potential has always been in the patient's own blood. We just finally mapped the iceberg well enough to actually put it to use. Which brings our journey full circle. Today, we took a deep dive beneath the surface of the female reproductive system for you. We moved past that tiny 5 mm visible tip of the clitoris to map the expansive 50 mm hidden wishbone, the vestibular bulbs, and the dense nerve networks that medical textbooks honestly ignored for centuries. We unpacked how the O-shot isolates the golden serum of your own platelet-rich plasma to trigger a biological construction crew rebuilding collagen, forming new blood vessels, and repairing nerves.
And we saw exactly why a one-size-fits-all approach fails. Practitioners must master the anatomical variations of each patient's unique crura to safely customize their lateral injection vectors. Only by navigating that specific 3D maze can they ensure this powerful regenerative fluid reaches exactly where it needs to go to cure incontinence, eliminate pain, and restore intimacy.
It's an incredibly empowering realization that so much potential for natural healing and restored function has always been there, just waiting beneath the surface. Which leaves you with something to ponder long after we wrap up today. If our medical understanding of something as fundamental as human anatomy has been this incomplete for so long, treating the clitoris as just a tiny surface structure rather than a massive, interconnected internal network, what other hidden icebergs exist inside our own bodies, just waiting for modern science to truly discover and heal them?